Good morning and welcome to the press conference for the 54th annual meeting of the Society of Thoracic Surgeons. I'm Robin Cohen, Chair of the Workforce for Media Relations and Communication. Our next discussion is entitled Refusing Surgery for Esophageal Cancer May Cause Severe Consequences for Patients. It'll be presented today by Dr. Sebron Wood Harrison from the Cornell Medical College and New York Presbyterian Brooklyn Methodist Hospital, and we're fortunate to have it discussed by Dr. Mark Allen from the Mayo Clinic.
Thank you, Dr. Cohen. I'd like to echo all the other presenters and thanking the STS for giving us the opportunity to talk about this. Our talk today is about something we feel strongly about. It's the consequences of refusing surgery for esophageal cancer for patients who have been recommended to undergo esophagectomy. It was a study of the National Cancer Database. So to start with, why is it that patients refuse esophagectomy? And the short answer is we don't know right now. We have surmised a few things that could potentially be the issue. For one thing, there has been, and for very good reasons, there have been an emphasis on shared decision-making. It's been an attempt to empower both the patients and the patient's loved ones and for them to have some control in the decision whether to undergo surgery. But obviously, the flip side of that is that oftentimes patients can make a decision that we as surgeons don't necessarily agree with. There's also other options, such as the fact that there are newer, there are other reasonable treatment options, particularly endoscopic treatments for the earliest stages of esophageal cancer. And also, a lot of times these patients will present symptomatically, and it could be the case that after they get their induction treatment, their symptoms resolve, they're feeling better, and they just don't wish to undergo surgery at that point. Probably the two greatest issues that we're concerned about is a fear and a misunderstanding of the surgical procedure itself and a lack of knowledge about long-term outcomes. So with that in mind, the goals of our current study, we wanted to determine the proportion of patients with locally advanced esophageal cancer who refuse surgery, to identify what treatments they do receive if they don't undergo esophagectomy, and then ultimately to assess the survival outcomes in this cohort compared to those who do receive surgery. To that end, we studied the National Cancer Database. We did exclude esophageal cancer patients who were T1N0 and those who were stage 4. In the cancer database, it can be listed those patients who are recommended for surgery but do not have surgery. And we studied those patients for the reason for no surgery was that the surgery of the primary site, quote, was recommended by the patient's physician, but this treatment was refused by the patient's family member, or the patient's guardian. We excluded those patients who were recommended to undergo surgery but did not undergo esophagectomy for, for unknown reasons. We really wanted to focus simply on those patients who were recommended to have surgery and they refused it. And then finally, we compared the demographics and overall survival of the cohort to those who underwent esophagectomy. So what we found, 708 patients, or 5.7% of the patients who have been recommended for surgery refused esophagectomy. There are some important caveats and limitations to this to go through. First of all, the reason for refusal was not noted in the database. It's also not specified whether a surgical consultation had been obtained or if this refusal was documented by another treating physician. And probably one of the most important aspects or limitations is the fact that the timing of refusal is not documented. However, we feel that this is a very significant issue for thoracic surgeons because the number of patients who've been refusing esophagectomy has continued to go up over the last decade. Looking at the patient demographics of those who refuse esophagectomy, females were more likely to refuse surgery than men. Those identifying with non-white race were more likely to refuse surgery. And probably less surprisingly, those with more significant comorbidities were also more likely to refuse surgery. Looking at the tumor characteristics itself, squamous cell carcinoma, those patients were more likely to refuse surgery. And interestingly for us, patients with earlier clinical stage 1 and stage 2, were more likely to refuse surgery than those with later stage. So if they refused esophagectomy, what treatment did they receive? And you certainly can be tempted to think that these were patients who had, quote, given up on their treatment, but that's actually not what we found at all. Roughly 3/4 of the patients received some combination of chemotherapy and radiation, so presumably these patients were wishing to be relatively aggressive with their treatment. In fact, patients who who refused all treatments only made up about 15% of our patients. And patients who received radiation alone or chemotherapy alone were only 8%. Looking at overall survival among the patients who had refused surgery, the patients who refused all treatments did worse than the others. And those who received some combination of chemotherapy and radiation did the best, with the median survival of that entire cohort of just over 21 months. Next, we want to compare overall survival for those who had received esophagectomy versus those who refused surgery. In an attempt to eliminate some of the bias in the refusal group, we did exclude those patients who had refused any treatment since their overall outcomes were quite poor. And even eliminating those patients from the analysis, we found that there was a survival benefit for those who underwent esophagectomy. The median survival in the surgical group, 35.6 months, compared to those who refused, 24.8 months. We did perform a propensity match analysis in order to attempt to eliminate or alleviate some of the inherent bias in this. And even in the propensity match data, we found that there continued to be a survival benefit in the surgical group as opposed to those who refused. On multivariate analysis, those predictors of overall survival, again, several of these are not surprising. So predictors of poor survival, increasing age, more comorbidities, greater stage. But still, we need to point out the fact that refusal of surgery maintained was a predictor of poor survival. So in conclusion, we found that older patients, females, non-whites, and those with more comorbidities were more likely to refuse surgery. Also, patients with lower clinical stage were also more likely to refuse. Those who refused surgery had significantly worse overall survival than those who underwent esophagectomy as part of their treatment. But to put this into perspective, or what's the importance of this, for one thing, it helps us understand who those patients are who refuse surgery. So perhaps we need to tailor our surgical discussion or personalize the discussion for those particular patients. Perhaps even try to better understand why those patients who've been recommended surgery have refused. But I think even the greater picture, and something that doesn't come across in these database studies, is the fact that the determination of, quote, operability, and those types of discussions regarding surgical risk should be managed by thoracic surgeons. And although it is understandable that patients may wish to avoid the immediate morbidity and quality of life issues associated with surgery, that should always be in the context that that may come at a little bit of expense of overall survival. And discussions regarding long-term survival and not just short-term outcomes should be a major part of any shared decision-making process, and we certainly feel that thoracic surgeons should be involved in that discussion. Thank you.
Thank you, Dr. Harrison. I'm Mark Allen, one of the thoracic surgeons at Mayo Clinic. I've been practicing thoracic surgery for about 28 years, and I appreciate your study. I think it's very well done. You've taken this national cancer database and tried to mine that data to answer a very important question, which is, as you've shown in your slide, is becoming more and more relevant to day-to-day practice for us. As surgeons, we are always interested in not only quality or quantity of life, or how long you're going to live, but your quality of life as well. It doesn't really do us very good to make you live a long time if your quality of life is very poor. So we have to look at both of those factors, and I think this question of whether or not you should have an esophagectomy after treatment relates to that. It's not uncommon for me to see a patient with esophageal cancer initially. At the Mayo Clinic, we see them in a multidisciplinary fashion, so they're seen by surgery, myself, the chemotherapy doctors, and the radiation therapy doctors. They go off and they get their chemotherapy, their radiation therapy for 5 weeks, then we wait a month, and they come back, and oftentimes there's no evidence of any residual cancer in that patient. And then you have to have a discussion with that patient. Is it worthwhile to go through an operation to try to increase the cure rate? And we've never really known what that percentage of increase in, and I think this study indirectly gets at that. And now I can tell patients that there's about a 20% increase by having an operation. And it's important because it's not a little operation. No matter how you do it, minimally invasively or open or transhiatally, it is a big operation. And it's going to affect your life for the rest of your life because it interferes with your eating. It's a very social thing for us to eat, but every time you eat after you have an esophagectomy, it's going to be different. So it is a serious discussion that we have, and I think this study points out that now we have another figure that we can give patients, this 20% increase. And for that 20% increase, yeah, you have to go through the risks of an operation, you have to have the morbidity of an operation, the change in the lifestyle, but that's something that we want to discuss with them. I think it's very important for patient education as well. There's a lot of information out on the internet. They talk to their friends that have had an esophagectomy. A lot of times the operation doesn't go that well, and they don't get an honest opinion about what is going to happen or what to expect from that operation. So it's incumbent upon us as surgeons to be honest and be transparent about this operation, what it involves, how long it's going to take to recover from, what's your lifestyle going to be like afterwards. That's an important thing. So I think this will become more of a problem as we get better and better chemotherapeutic agents and radiation therapy agents. We'll see more and more patients that are apparently cured from their preoperative treatment, and we have to decide whether to operate on them at that time. It's a little bit tricky for the esophagus and radiation therapy because there's sort of a window to operate on them. Maybe somewhere between 4 and 8 to 10 weeks after the end of the radiation therapy is the ideal time to operate on them for the lowest chance of a complication. If one waits, if the cancer goes away and then you wait till it comes back, the risk of an operation go way up because of the effects the radiation therapy has on the tissues. So again, thank you very much for, I think, a very important study, and I'll probably use this a couple times a week when I see patients to explain to them why they should or why they should not undergo an esophagectomy. Thank you.
How long is the recovery?
Sure. So usually tell patients they'll be in the hospital about a week, and then they go home. And then at home, they're up and about, they're moving around. But I usually tell them it'll be another 6 to 8 weeks before their diet has been advanced to what they were having before surgery. And then usually 6 months, I tell them, before they can go through their day and not remember that they've had an esophagectomy. So, as Dr. Allen was saying, this is an extensive surgery. It requires typically an abdominal portion of the case, a chest portion of the case, and even sometimes a neck portion of the case. So it is a significant undertaking for the patients to go through.
But you're saying that the surgery, even as stressful as that is, has a mortality benefit.
Yes.
The question is, as you brought up in your comment on it, is that how much quality of life? So you get 20%, and how much have you lost? Have you lost 18% because you really are miserable?
Yeah, well, if you die, you've lost 100%. So I would say that, again, short-term outcomes, these patients are for 6 to 8 weeks. They're taking limited intake. They're usually getting a lot of nutrition through a feeding tube that we've placed at the time of surgery, although not all surgeons do that. But after 8 weeks, they're back eating. They're back to their lives. So, I mean, you're trading 1 to 2 months of a difficult postoperative course with a 20% improvement in overall survival. But to your point, I mean, that's why I think it is so important not to be honest and to focus on the short-term outcome, but to always have that in the context of long-term cancer cure, cancer survival.
I can make a comment on that. I don't know, maybe 10, 15 years ago, we went back and found all the patients that had an esophagectomy. And we kind of did a very careful study of both physical attributes and mental attributes. And yes, they were worse off from an eating standpoint of view, but on a psychological standpoint of view, they were some of the happiest people in the survey. And we sort of hypothesized that, yeah, they have some difficulties eating, but they're very happy because they kind of beat cancer. and they felt they were very lucky and they were very fortunate to be alive. So from a psychological standpoint of view, they were pretty happy that they made it through the treatment and survived.
And how does this fit with immunotherapy? Is there, you talked about radiation and chemo, but what about immunotherapy?
I'm including the immunotherapy in chemotherapy, because that's kind of a part of chemotherapy now. It's just kind of getting started, and there's various trials. But that's why I think it'll be more and more of an issue, because we will see them back after their neoadjuvant therapy, and they won't have any residual tumor to see.
Yes, but, let me finish that. But with immunotherapy, it's different than chemo in that chemo is not really curative the way immunotherapy can be. So doesn't that change your conversation? Because if they're a pembro or a nivo patient and they stand a chance of just, that's it, they're done.
Right.
That's not what we're saying with chemo. We're buying time.
No, there's still some patients that are cured with chemo, the standard sort of cisplatin 5-FU chemotherapy alone. We don't really know the numbers yet for immunotherapy. But the hope is that there will be a much higher response rate and a much higher cure rate. It turns out that if you have a good response rate, when we do surgery, those are the best patients. They have the best 5-year survival rate. They're sort of 40–50% 5-year survival rate.
Ed Sussman, Dr. Scott. Dr. Allen, have you calculated or quantified what might be called internet interference in decision-making?
Yeah, I would say almost everybody now not only looks up me when they come to the office, but they've had take a tour of the internet, and they read stuff about what it's like to have an esophagectomy. Unfortunately, I kind of tell patients that those patients that have a good result from an esophagectomy, they're not on the internet. They're out enjoying their life. Those patients who are having a bad outcome are all over the internet complaining and moaning and writing bad stories. So it's a little bit of bias. That's what I mean about trying to be open and honest. Look at your results. Try to get some objective data so you can tell patients what it's going to be like. But there is a lot of people that read the internet, and it's difficult to counteract some of the misunderstandings they have of the operation.
You reported that patients with lower stages were more likely to refuse operation, which is opposite to what I would have expected. And then I heard Dr. Allen say that a lot of the patients that were lower stages were cured with chemotherapy or radiotherapy. Did you separate the two groups of patients to see whether it was those who had been cured versus those who were not?
Yeah, we did not, and that is a very good question that we have considered doing subsequently to that point as well. I had assumed that it would be those patients in the higher stage who maybe feel a little bit more skeptical of their treatment, who would have dropped out. But actually, it was surprising that it was the earlier stages, and I wondered if it is perhaps they weren't as symptomatic, and so therefore they weren't as symptomatic, had a good treatment with chemoradiation, had no symptoms, and didn't wish to go on further with their treatment. But it was very counterintuitive for me as well to have seen that.
I think you're probably right. It's kind of hard to tell a patient who's completely asymptomatic, eating, having a good day. We're going to put you in the hospital for a couple of weeks and change your life for quite a bit, for a big operation. So it doesn't surprise me that the people with low stage said, no, I don't really want to have an operation. I'll take my chances.
How does it change? I mean, you can't eat the same food?
I sort of tell people that, you're going to have 6 small meals a day instead of 3 big meals a day. We tell patients that your stomach's a little bit smaller. You lose some of the motility function because the nerves that are next to your stomach and your esophagus get taken out with the operation. I tell them that, your eating will be different afterwards. I must say most patients that come back a year, they're back to 3 meals a day and they're pretty much eating what they want to eat for the majority. There's certainly a group, maybe 10–15% of patients that have a lot of trouble eating afterwards, and we have to work with those and figure out a special diet and whatnot. But the majority, after a year, are back to eating, 3 meals a day. And just socially, it's hard to, I have a patient from England who came back, I don't know, a couple of months after an operation, and I said, well, how's your eating? And she said, well, I graze. She kind of eats all day long, a little bit all the time. And that's, I think, initially what happens, but I think as time goes by, they go back to eating a regular 3 meals a day. Because just socially, it's hard to, you can't have a meal every half an hour. People sit down, they have breakfast, lunch, dinner with their family or their friends, and that's just sort of the way life is.
Are there any food groups that are discouraged following esophagectomy?
You can answer.
No, I mean, I do get that question a lot, actually. And so, sometimes patients after esophagectomy can have difficulty with bloating of their stomach. And so I say always, if there's things, particularly before surgery, that had caused you to have some problems with that, you may want to eliminate that. Additional acid can sometimes be an issue as well. So if patients have had certain trouble with things that cause excessive amount of reflux, I'll recommend them stick away from that, yeah.
Yeah, I sort of facetiously tell patients you can eat anything that doesn't bother you. But typically things that will bother them, there's something called the dumping syndrome. So when you do an esophagectomy, you have to take the nerves out. So your stomach empties into the small bowel too fast. And that amount of material that goes into the small bowel sometimes will cause a systemic reaction with flushing and sweating, and crampy abdominal pain, diarrhea. So some food groups, for example, a milkshake with a lot of solute content in it will cause the dumping syndrome. Interestingly, when we go to Japan and talk to the Japanese surgeons, they've never heard of dumping syndrome because their diet doesn't have the high-fat, high-solute diet like American diet has. So there is some dietary modifications, and usually, as I say, it takes probably about a year or so to patients to figure that out, and they figure out what they can't eat and what they can eat. And it's so variable that I can't really predict for any one patient what it's going to be like.
Okay, very good. Thank you very much.
Thank you. Good job.
Thanks so
Nice
much.
study. That's a
Thank
good
you.
study.
Oh,
I
thank
really
you.
like that because now I know what to tell patients. 20% chance